taking a look at thyroid disorders, both hypo and hyperthyroidism. We're actually working in Chapter 32 of your textbook. It's only a select section of pages in Chapter 32, so please refer to the Moodle page for those specific page numbers. So it's not the full chapter. You should have already completed the lesson in Moodle by the time you're listening to this lecture. That will help a lot in going over the normal functions of the thyroid gland and the hormones T3 and T4. You should be familiar with the image that you see right here in terms of the feedback and regulation of normal thyroid levels in the blood. We frequently refer to thyroid hormones, meaning the T3 and T4. We are not referring to calcitonin when we say thyroid hormones. That is actually a hormone produced in the thyroid gland, but has a very different function. Calcitonin is regulating calcium levels in the blood along with parathyroid hormone. So that's not what we're talking about here. We're exclusively looking at T3 and T4 made in the thyroid gland, and also the associated TSH, which is necessary for T3 and T4, and that's made in the anterior pituitary, and the thyroid releasing hormone produced in the hypothalamus. So if you are not familiar with this feedback process, this regulation process, please go back and look at the lesson in Moodle. You should also be familiar with the role of iodine. The 3 and the 4 in the T3 and T4 refer to the number of iodine molecules that are actually bound to the protein. So it's important that you understand this mechanism. The book gives you a little bit of introduction, but the lesson gives you a much better overview of that. In terms of the thyroid disorders that we're going to be taking a look at, we can classify disorders in general terms as either primary, secondary, or tertiary. And I do want to mention just a little bit about that before we look at the functions. Primary disorders refer to, and this terminology is primarily used with endocrine gland disorders. But in terms of the thyroid disorder, a primary disorder is when the problem exists with the gland itself. And therefore, whatever disease process is going on, whether it be hypo or hyper, the problem is with the either under or overproduction of T3 and T4 at the gland itself. So it isn't the amount of TSH, the anterior pituitary, or the TRH, in the hypothalamus, that are causing the problem. They're behaving normally, and it is the gland itself that is not functioning correctly. For example, if you have high levels of T3 and T4 in the blood, you'd be stated as being hyperthyroid state. That's a high level of T3 and T4. In a hyperthyroid state, we expect that the feedback would be such that the TSH levels and the TRH levels would be low. And so if I were to draw a serum blood test and look at these levels, particularly TSH, I would find that to be low, and I would find that T3 and T4 to still be high. That would tell me something's wrong at the gland itself. TSH is low. That's what we expect to have happen. And as mentioned in the lesson, TRH will not be something we normally test for in the blood. The TRH simply travels from the hypothalamus to the anterior pituitary directly through that hypophyseal portal system, that blood supply, and therefore TRH really does not enter into the general circulation and is nearly undetectable in blood levels. If it were to be detectable, that would indicate we had a hypersecretion of it in the hypothalamus. That's a different issue than what we're explaining right here. So T3 and T4 are high, TSH is low. That's a primary disorder. Something's wrong with the gland. It's not behaving as it should be. TSH is dropping low. It should reduce the amount that's being produced, and that's not happening. Likewise, if T3 and T4 are low, and therefore we're in a hypothyroid state, so they're low levels, but the TSH level is high, saying, come on, thyroid gland, make some more, but the gland is not responding to these high levels of TSH, that is also a primary disorder. It's primary hypothyroidism. In a secondary disorder, the problem's not with the gland. The thyroid gland itself is behaving as it should, and it is the anterior pituitary that is behaving inappropriately or over or under secreting. For instance, if T3 and T4 levels are high and you're in a hyperthyroid state, but TSH levels are also high, what should be happening is as T3 and T4 levels rise, it should inhibit the TSH. If that does not occur and TSH levels continue to be overproduced, it'll overstimulate the gland and we will continue to have high levels of production of T3 and T4. So that's a secondary disorder. In a tertiary disorder, as I mentioned before, that's a problem up here with TRH. That is the least common situation. It can occur, and in that case, TRH levels would likely be detected in the blood supply in a hyperthyroid state. In a hypothyroid state, you'd still be more likely to find that issue occurring with TSH. So if the levels of TRH are low, you would not necessarily find them in the blood anyway. That's going to be less easy to determine from a blood test. And if TSH levels are low, that's what we expect to have happen. TRH is low, TSH levels are low. That's a normal process. So if there's something wrong, though, and the hypothalamus has stopped producing TRH, it's going to be a little harder to detect, and you're going to need more than a blood test in order to determine that. You're going to need a CAT scan or some other diagnostic test to determine what's going on in the hypothalamus. So primary and secondary are what we most commonly see. Tertiary are far less common and much more difficult to detect. In terms of the functions of the thyroid gland, I refer you again back to the lesson and also to pages 777 and 778 in your textbook. It's there that they will address those functions. It is expected that you have a good understanding of that. That will make it a lot easier to discuss what happens when there is a disease process that's taking place. Just a little bit about goiters. Goiters are enlarged thyroid glands. That's all they really are. It's an increase in the size of the gland. They may be diffuse, which means the entire gland is enlarged. They may be nodular. Nodular refers to lumps or bumps that can be palpitated when you feel the gland. And it also may be an enlarged gland that is asymmetrical. So it may be that only one portion or one side of the gland is enlarged. Diffuse simply means the gland is equally enlarged. It could be one wing of it or the other. Nodular is where lumps are enlarging in it. A toxic goiter refers to one in which it is usually cancerous or disease, and a non-toxic is simply an enlarged or overstimulated gland. In all cases, you're going to see a goiter forming because it's being overstimulated, primarily due to increased TSH levels. The overproduction of T3 and T4 is not necessarily what causes the goiter to enlarge, although it can in more extreme cases. Primarily what we're looking at is a large amount of stimulation of TSH. That being said, goiters occur in both hyper and hypothyroidism, because in both cases there can be hyperstimulation of the gland by TSH causing it to enlarge. All right, taking a look at hypothyroidism first. We've got a couple different types to look at. First, let's talk for a minute about congenital hypothyroidism, and that is what you're born with. Even congenital can be both primary or secondary, a problem with a lack of development of the gland itself or lack of function of the gland, or it can be with the anterior pituitary. Lack of proper secretion post-birth can be a significant problem in terms of impairing growth and normal development of the child. There's definitely can be mental retardation, and there are significant growth disorders linked to hypothyroidism if it is present congenitally. However, it's important to point out that if the mother is normal, then even though the infant may never have, or the fetus may never have developed the thyroid gland or may have some abnormality with it, the T3 and T4 do cross the placenta, and therefore the mother's levels of T3 and T4 provide ample protection or development for the infant or fetus. So, point being, upon birth, if mother is normal, even though the child may have the disorder, they have yet to manifest any symptoms whatsoever. They will appear totally normal, and so therefore it's important to test the blood serum levels of TSH, T3, and T4 upon birth to ensure that the thyroid has developed normally. If in fact, however, it's not detected, within a few weeks of life, there will not be enough T3 and T4 in the baby's system. The protection that was there from the mother will be lost. It's not enough from what might be provided, for instance, in breast milk. That would not be sufficient to provide for the needs of the child. So kinds of manifestations, things you can see in a developing infant with hypothyroidism: they'll have difficulty eating, swallowing. Their vocal cords may be affected, so their cry may sound very hoarse. They will have low muscle tone. Metabolism is slowed down. This is really the same manifestation you would see in an adult. So the processes of digestion slow down, but with the high metabolic demands that an infant has in growing, this can be very significant. So the muscle tone in the digestive tract is low, muscle tone in the body is low. The baby will sleep a lot, which may seem great. You have a baby who's sleeping a lot, not realizing that they're not growing and not developing appropriately. Oftentimes the condition is not one in which the gland is missing entirely, but the gland is underproducing, so you're in a hypothyroid state because you don't produce enough, and so therefore it may not be immediately detected, and then it's not until you start watching the growth and realize that their skeletal system is stunted, teeth are being delayed. The overall growth can lead to cretinism if in fact there's not some intervention that takes place. And of course it can be treated simply by hormone replacement. In adults, we have primary hypothyroidism with the most common form known as Hashimoto's. So Hashimoto's is an autoimmune disorder. It does cause a goiter. So it will manifest itself with that, and that may be one of the first things that helps to diagnose it. So there are other ways in which you can get primary hypothyroidism from deficiency of iodine, for instance, in a diet can be one of the. Actually, you can have deficiency or too much. Too much iodine will also block production. So iodine. Insufficient or excessive amounts in the diet. Some infections can cause thyroiditis or an inflammation, but the big one I want you to know is the Hashimoto's, the autoimmune disorder, because that is the more common one. Again, causes a goiter. Oftentimes it is a nodular goiter that develops with that. The manifestations for hypothyroidism, I listed a couple big things here, but there's a number of things. The fatigue, cold intolerance, and there's a table in the book that covers these as well, but there will be weight gain, there may be weakness in the muscles and pain in the muscles, joint pain, constipation. Again, the processes in the body are slowing down, so even though the patient may eat at a normal, not an excessive level, they're gaining weight, they're not burning energy, and so it's all converting into fat. Their heart rate will be slow. That's referred to as bradycardia, B-R-A-D-Y-C-A-R-D-I-A, bradycardia, the slow heart rate. There may be some hair loss. The nails may become brittle. Decreased fertility and libido are also associated with Hashimoto's, hypothyroidism in general, but most definitely with Hashimoto's. Then you have this condition referred to as myxedema. Myxedema is a type of edema. Edema is an excess fluid accumulation in the extracellular space. That's what edema is, fluids. You've seen, somebody certainly in your life, you've seen swollen ankles or swollen hands. Maybe you yourself have had it. That's edema. Myxedema is a specific kind of edema in which you will find what we would refer to as a hard, non-pitting edema. If you push on the skin that's swollen, it's hard. It's not soft and squishy like fluid in there, but it's hard. It doesn't make an indentation or a pit when you press on it. And it's caused by something referred to as mucins, M-U-C-I-N-S, mucins. These are proteins that are associated with mucous membranes. These proteins trap water, so it's not just water, but it's water and proteins being trapped together in these interstitial or extracellular spaces. So myxedema is a form of edema specifically associated with hypothyroidism and even more specifically with Hashimoto's. So you can see mixed edema in other types of hypothyroidism, but definitely link it with Hashimoto's as well. So mixed edema, a hard, non-pitting edema. Edema interferes with fluid flow, with blood flow, with the diffusion of nutrients, oxygen to tissues, can be very damaging. And actually, mixed edema can actually lead to hypertension or high blood pressure because it's hard to get the blood pumped through the areas through those small capillaries because there's all this excess fluid and proteins accumulating there. And then myxodematous coma is a very severe form of hypothyroidism. Again, still linked and associated with Hashimoto's, but with hypothyroidism in general. And it's a severe case. It only really occurs when you have untreated hypothyroidism of any kind. If you have hypothyroidism and you don't provide some sort of hormone therapy, some sort of treatment for it, it is possible to move into this myxodematous coma state. So in this case, we're talking about three major aspects that happen. You have carbon dioxide retention, and when you have excess carbon dioxide, that's going to lead to hypoxemia. Might be a new term for you. Hypoxemia is lack of oxygen in the blood. There's too much carbon dioxide. It's lack of oxygen in the blood. This basically leads to a hypoxic or hypoxia state. So myxodematous coma will cause hypoxia, specifically hypoxemia, not enough oxygen in the blood. There will also be fluid and electrolyte imbalances that occur. That's the second major aspect of myxodematous coma, and we'll talk more about fluid and electrolyte imbalances when we get to fluid and electrolyte chapter, and we'll swing back around to some of what goes on here. And the third is hypothermia. In hypothermia, you will have the body getting very cold. Energy is not being produced because the metabolic rate is dropping so low. So those are the three major aspects of what's happening: carbon dioxide retention, hypoxic state, fluid and electrolyte imbalance, and hypothermia that occur, the slowing of the body's metabolism and body temperature. In this condition, it's oftentimes irreversible. It can start to progress and then progress forward very rapidly. Now, usually it's triggered by some kind of stimulus. So you are already in a hypothyroid state. You are not properly managing it. You're not taking your hormone therapy. You're not getting treatment at all. Then an infection occurs. Some kind of trauma occurs. You're given an anesthetic, and somehow you're going under surgery, given an anesthetic, and no one tested for what your thyroid levels were at and didn't realize you were having this problem. And some kind of like I say, I think I mentioned already, some type of trauma can occur. You're in an accident of some kind. Some high stress situation occurs, can send you over the edge into myxodematous coma. Other manifestations that are going to occur, you are going to have a very severe bradycardia, very low heart rate. It will likely lead to cardiovascular collapse. The vessels will stop pumping. The heart stops pumping. The pulse rate drops, and the flow of blood through the body diminishes. You're going to have hypoventilation. The breathing rate is going to slow dramatically. You'll have hyponatremia. That's very low sodium levels. Hypoglycemia. Not enough glucose available in the body to make the ATP for the energy that you need. Patient will go into lactic acidosis, and we've not talked about acidosis really at all, but that's something we will hit on more when we get into our fluids, electrolytes, and pH chapter in a couple of weeks. But lactic acidosis is, again, lactic acid comes from lack of mitochondria. It's part of that hypoxic state, so consider those steps in developing hypoxia. That's where the lactic acid is coming from, particularly in the skeletal muscles. You're going to see brain function start to diminish, and that will lead to psychosis, and there'll be an increase in cerebral spinal fluid pressure, so increased fluid pressure on the brain. Again, this is a very serious state, and if left untreated, can lead to death. All All right, and then our other condition is hyperthyroidism. Hyperthyroidism, or sometimes referred to as thyrotoxicosis, is a condition in which you have excess amounts of T3 and T4. It can be primary, which is most common, something wrong with the gland itself, and of course it can be secondary, something with the pituitary, but most common is with the gland itself. And the most common condition that we have of primary hyperthyroidism is Graves' disease. And Graves' disease is also an autoimmune disorder, and in reality it's probably the opposite side of the coin of Hashimoto's. There's been a lot of research out there to say that the mechanisms leading to Graves are actually the same mechanisms that will lead to Hashimoto's, and so they're very similar in the process of an immune disorder. But of course the diseases are quite different. One is a very rapid increase in T3 and T4, hyperthyroidism, and one is a very low level of T3 and T4, very low metabolic rate, in hypothyroidism. General manifestations for hyperthyroidism of any kind are a rapid heart rate, which is tachycardia, increased body temperature, an elevated metabolic rate. So now metabolism is very fast. This puts a great strain, by the way, on the cardiovascular system, asking for the heart to beat faster, the blood to pump faster, to try and meet the demands of the body. The person may appear nervous, almost manic in state. There may be a tremor in their hands or in their muscles as they seem like they're constantly moving. There'll be weight loss without any changes in diet, and in fact they may eat more and still be losing weight. They may have a shortness of breath because their respiratory rate cannot keep up with the demands of their body. They may have hair and skin that appears very thin. Again, not enough ATP, energy metabolic processes to meet the needs of the hair and the skin, so it starts to actually thin, which is similar to what you see in hypo, except there it becomes more of a brittleness. Here it is just thinning. A goiter is very common. And then when we look at the manifestations for Graves in particular, in Graves there's almost always a goiter. You will see what we refer to as exophthalmos, and I apologize I didn't type this on the PowerPoint, but it is in the book. Exophthalmos refers to the bulging of the eyeballs. It actually can get to the point that it's so bad that the eyelids will not actually close properly to cover the eyes. It's really a problem that occurs with the extrinsic eye muscles. It can lead to damage to the optic nerve and the cornea. And if it's not dealt with early on, it can be irreversible and could actually lead to blindness if in fact some interventions do not take place. Graves' disease most often affects women between the ages of 20 and 40. It is also triggered by a stress or viral infection, something that triggers that immune system. It's also been associated with conditions such as myasthenia gravis, which is a defect in the conduction of nerve impulses at the neuromuscular junction. We'll look at myasthenia gravis towards the end of the course when we look at neuromuscular disorders, but there does seem to be a linkage between Graves and myasthenia gravis. Emotional stress sometimes can also lead to the development of Graves' disease. On rare occasions with Graves' disease, you may find some dermopathy, which is a red swelling of the skin. It's particularly common on the shins and top of the feet. The thyroid storm or thyrotoxic crisis is the extreme version. We had myxodermatous coma for hypo. This is the extreme version for hyperthyroidism. So again, we're talking about a situation where likely the condition was not being properly treated in the first place. Same kinds of things can trigger it: stress, trauma, infection, or this is something if a patient suffers from diabetic ketoacidosis. So if they have diabetes mellitus, if they have diabetes, diabetic ketoacidosis is a condition that can develop, particularly in those who have type 1 or what used to be referred to as the juvenile onset. If they have type 1 diabetes, they're at greater risk for developing ketoacidosis. That occurs when they stop breaking down glucose because they can't get it into the cells. They start breaking down a lot of fats, and the keto acids are released from that fat breakdown. We'll talk a lot more about that as well. I'm just more or less mentioning the diabetic ketoacidosis here. When we get to the diabetes chapter towards the end of the course, that'll make a whole lot more sense. But that is linked with thyroid storm. So if you have a diabetic who also has a thyroid disorder, and that may be the case, particularly since diabetes type 1 is an autoimmune disorder, so Graves' an autoimmune disorder, these conditions do sometimes occur in individuals who are type 1 diabetics, and so their ketoacidosis can lead them into thyroid storm. Some symptoms that happen here: a very high fever, extremely high output of their cardiac output, which can lead to a heart failure. The heart's beating so fast, trying to meet the demands of the heart of the body's system with such a high metabolic rate that the heart beats so fast it doesn't have time to fill and pump out any blood. There can be vomiting, diarrhea, delirium will develop, and this is another one that proceeds rather rapidly and often can lead to death. So if you get into the thyroid storm, it's tough to get your patient back, to get him stabilized and back, and it may very well lead to his death. Diagnosis of hyperthyroidism is primarily just looking at the T3 and T4 levels and the TSH levels. And treatments usually require that you remove the thyroid gland or treat it with some radioactive iodine, some way to destroy the function of the gland and reduce. Actually, what will happen usually is if they don't remove the full gland, they will treat the gland such that it stops producing T3 and T4 altogether, and then you will replace that hormone with a synthetic version of T3 and T4, and therefore control the amount that exists. So again, be sure that you read the sections in Chapter 32 as indicated on the Moodle page for this information. This is one of your primary disorders linked to metabolic problems, things with the metabolic rate. So that's why we looked at this disease here. It really links back to your processes of glycolysis, Krebs, and the ETS. You understand metabolism, recognize that the hormones T3 and T4 influence metabolic rate, in fact are crucial for maintaining metabolic rate in the body, and these are disorders that can interfere with that.